Thank you, and thank you for that introduction. So it's a pleasure to be here today. I'm going to be talking about a study that is ongoing in the United States called RECOVER. It's a study that includes an adult, pediatric, and autopsy cohort, and I'll be talking specifically about the adult cohort and the manuscript that was the first manuscript to come from this RECOVER study in JAMA last June. So RECOVER, researching COVID to enhance recovery, is a longitudinal cohort study, including, as I mentioned, adult, pediatric, and autopsy cohorts. It includes 200 enrolling sites across the United States, 33 states, plus Washington, D.C., and Puerto Rico. And it has the goal of diversity of sites and participants. The primary objectives of the adult cohort study include defining post-acute sequelae of SARS-CoV-2, or PASC, and estimating its prevalence, characterizing the symptoms, organ dysfunction, natural history, and the distinct subphenotypes of long COVID, identifying the demographic, social, and clinical risk factors for the persistence of long COVID as well as recovery, and ultimately characterizing the biological mechanisms underlying PASC pathogenesis in hopes of advancing treatments. So I'm going to begin by just giving you a brief overview of the design of this large study. And then I'll go into our methodology and some of the findings that we have. So the adult cohort study includes two subcohorts, an acute cohort that's on the top there. Do I point? Is that showing? There we go. Can you see that? Yeah. So the acute cohort that's indicated on this top panel, that includes individuals that were recruited during the acute phase of their infection, so within 30 days. It also includes uninfected individuals who had a negative SARS-CoV-2 test during that period. We also have a post-acute cohort that includes individuals that were recruited more than 30 days after that first infection. So there are really two distinct subcohorts within the RECOVER study. Both of those groups were followed longitudinally at 3-month intervals. So they're all coming in every 3 months. And you can see for the post-acute cohort in the bottom, some of those individuals are coming sort of within that first 45 days, which we call a baseline visit. But some are entering the study, which is indicated by the rectangles here, at later intervals, so at 3 months, 6 months, 9 months, and actually up to 36 months after their first infection. So they come in at different stages, and we follow everybody for every 3 months. So it's important to note some of the timeline with respect to recruitment for these different cohorts, because it really informs how we interpret any findings from RECOVER. So RECOVER began in February of, the pandemic began, of course, in February 2020 in the United States, and vaccines became available in December of 2020. The study, RECOVER study, began in October of 2021. That's where we had our first participant enrolled. And that was after a widespread availability of vaccines. And the post-acute cohort includes individuals that have infections that occurred during the pre-Omicron variant dominance, so that's before the Omicron variant became dominant, as well as individuals who were enrolled after that became dominant, that variant became dominant. And we also have individuals in the post-acute cohort that are unvaccinated as well as vaccinated. The acute cohort has more individuals that are recruited after the Omicron variant became dominant, and again, after the vaccine became widely available. So we're looking specifically for this first analysis at 44 self-reported symptoms. So these, again, are measured every 3 months for individuals, and they fall into these general categories and listed here, and range from general symptoms to cardiac, dermatologic, musculoskeletal, neurologic, psychiatric, gastrointestinal, et cetera. So our first look at the recovery data that we did last spring included just under 10,000 adult participants. They were all over the age of 18. And we had, among those, about just over 8,500 infected individuals and just over 1,000 uninfected individuals. And our goal was to define long COVID using data-driven methods based on the symptomology. So using the 44 self-reported symptoms to come up with a definition of this syndrome of long COVID. This is the first part of our analysis that I'm going to present today. It's part of a much broader analysis that we're intending to do that's going to integrate multiple additional data modalities to refine this definition. So I really want to emphasize here that the definition that we initially published on and I'm presenting today is just focused on the symptoms, and we expect that it will be augmented to include other data modalities. We are also starting to look at the subphenotypes, and I'll present some information there as well. But there's many additional analyses that we'll intend to do. So returning to our study design, again, this is the longitudinal trajectory that we have. The analysis cohort that we used for this first analysis focused on participants who had at least one visit 6 months or more after their initial infection. So we wanted to look at time points at least 6 months after the initial infection. And we used the first visit that occurred at 6 months or later after infection. So here you can see we have individuals who enrolled at 6 months, and we use, this is the rectangular box here is an individual who enrolled at 6 months, and we'll use their 6-month visit. For individuals who enrolled earlier, we'll use a follow-up visit that corresponds to their 6-month visit. And for individuals that enrolled at later time points at 9 or 12 months, we'll use that 9 or 12-month measurement for those individuals. So we're integrating information across the trajectory over time in this analysis. So conceptually, in terms of how we approached this problem of a challenge of defining long COVID is shown in this figure. So of course, the gold standard approach is that if we knew who had long COVID and who did not have it, we'd use this as what we call a label in a statistical model to identify the symptoms that are associated with long COVID. Of course, in this setting, we don't have that label. That's unobserved data for us. So this is depicted in the center panel here. We have the truth, which is infected participants either have long COVID, they have PASC, or they don't. But we don't have that information available to us, so that's hidden from us. What we do have is uninfected participants and infected participants. And so here I've just done a little diagram to show that we're measuring a symptom. Again, we're measuring 44 symptoms. This is just one of them that we've measured. And if we think of the shading as the frequency of that particular symptom in the corresponding group, we could say that perhaps we have a symptom like fatigue that has a frequency say, and just arbitrarily say 10% in the uninfected. What we expect is for those individuals who don't have long COVID, it would be a fairly similar frequency of that symptom of fatigue, while people who have long COVID would have a much higher frequency of that symptom. So it's denoted by this darker color. Our infected participants are going to be a mix of these infected participants with and without long COVID. So here I've denoted this with a sort of a color in between these two colors. So it's a mixture of the two. So for our analysis, we focus on the comparison between the uninfected and the infected participants. And if we see a difference in these groups, that is people with a history of infection versus those who don't have a known history, then we're expecting to pick up symptoms that are going to differentiate long COVID from the folks that don't have long COVID. So the way we did this is we selected symptoms using a penalized regression approach where the outcome in our model is a history of infection. So we're using that history of infection as a pseudo label in the model. And we use particularly Lasso in this case. And from that Lasso model, we assign scores to each symptoms based on the model fit, and then finally determine the optimal score threshold for identifying individuals with PASC. So this is just a descriptive of our cohort. The details of this can be found in our JAMA manuscript in June of last year. And you can see there are some notable differences between our infected and uninfected participants. Particularly our uninfected participants are slightly older and have some differences with respect to sex. So we have more male uninfected than a higher proportion of infecteds are female. Sex assigned at birth, and we also have differences with respect to vaccination status. So we did do some adjustments to make these groups more similar for the analysis. So based on fitting our Lasso model, we identified these symptoms that are listed in this table. These are the symptoms that are the ones that most distinguished individuals with and without a history of infection. So you can see here, each symptom is indicated, the corresponding log odds ratio, which is from the Lasso model, and a score that's derived by inverting this log odds ratio. So we have a corresponding point for each of the symptoms, which we can think of as something that captures information on the magnitude by which that particular symptom differentiates between infected and uninfected participants. So we see here the one with the largest score is smell taste, and then quite close to that is post-exertional malaise, et cetera. So in order to get a score for each individual, we add up the scores corresponding to the symptoms that individual has. So for example, if a participant has post-exertional malaise, brain fog, fatigue, and dizziness, then they'll have a PASC score of 7 plus 3 plus 1 plus 1, or 12 in that case. And then we defined a decision rule for determining the optimal score threshold for identifying PASC. And here the idea is that we expect to have a certain proportion of PASC in an infected as well as an uninfected. So what we're looking for is, in some sense, to minimize the amount of PASC that we have in uninfected participants, recognizing that some of our uninfected participants may actually have an infection that they don't know about. So we don't expect it to be zero in that group. So we were able to identify a score threshold of 12 for this analysis. And here we concluded that if an individual has a score of 12 or greater based on these symptoms, then it's very probable that they have long COVID. So we classify them as PASC positive. However, if their score is less than 12, we call them PASC indeterminate. And the reason for that is that we recognize that the symptoms are only one way of identifying long COVID, and we expect that there are some other subclinical manifestations or non-symptom related manifestations that are important for the classification. Just want to highlight two important aspects of these results. First of all, although these symptoms are the ones that most distinguish the infected and uninfected individuals, there are many other symptoms that are highly correlated with these. So symptoms such as dry mouth, weakness, headaches, etc., are very common among individuals with long COVID, and particularly within the recover cohort. However, those were not part of that sort of minimally sufficient set of symptoms that we identified for being able to distinguish the groups. Also want to emphasize that the score that we derived does not correspond to the frequency of the symptom. So if you recall, smell, taste, loss of smell or change in smell or taste was the symptom with the highest score because it most distinguished those with and without a history of infection, but it's not the most common symptom that we're seeing in long COVID participants. So here is a figure just highlighting some of the frequencies of the symptoms that are contributing to the score among individuals who meet the PASC positive threshold. So here you see post-exertional malaise by far is the most frequent, followed by fatigue. So although they don't have the highest scores, they are actually the most frequent. Just to highlight here that the scores did track fairly well with our PROMIS Global 10 measurements, including general quality of life, physical health, and everyday physical activity. So we do think as some way of validating this score, which again is very difficult to do when we don't have a true gold standard, but the fact that it did track well with these measurements was consistent. We also were able to identify subphenotypes within those individuals who tested or were classified as having PASC. And here you can see we identified 4 distinct subphenotypes that are in the first 4 columns of this heat map. And the frequency of each of the symptoms are highlighted here. So you can see there's some differences in those frequencies. The first cluster has a very high frequency of 100% loss of smell or taste, while the remaining clusters had a much lower frequency of that. And then cluster 4 here is a fairly extensive set of symptoms. So really briefly, in the last minute that I have, I just want to emphasize some of the significance and next steps here. So this is a very large study that's happening currently in the United States. It's the largest, as far as I'm aware, that includes up to, at this point, 15,000 adult participants. And it's a longitudinal follow-up study that has enormous power for that reason. What we're able to do here is to begin defining a framework that's going to be a launching point for additional studies. So having a data-driven definition of PASC, although it has certain limitations that are very clear, allows us to take the next step of starting to investigate mechanistic underpinnings of PASC as well as potential risk and resiliency factors. So again, we're going to continue working to integrate these additional data modalities and refining the definition. I also just want to really emphasize that this is in adults. We're currently working on developing a definition in pediatric populations, which we do expect to be different than what we're seeing in adults. And one of the opportunities and challenges with the recovered data is the ability to investigating time varying exposures, persistence, and recovery. So the analysis that I just presented was, of course, taking a cross-sectional look at this longitudinal data that we are collecting. And we want to begin integrating information, of course, not just from that initial infection, but integrating information on repeated infections, vaccinations and boosters, as well as the treatments that people are receiving. So we are beginning to do that, look at the data, and there's quite a lot more to be done there. So I just want to thank all of the participants enrolled in the Recovery Initiative and the National Community Engagement Group and all the patient, caregiver, and community representatives. I also want to acknowledge, I think Dr. Upi Sang is here, who's also been involved very actively in the study. We'll be hearing from her later in the meeting, as well as many others who've contributed to this first analysis. So thank you.